Hi, I'm Hersh Deo, an orthopaedic consultant from the east of England. I work at the James Paget Hospital and Spire Norwich Hospital, and I'm going to talk to you today about my experience with synthetics in MPFL reconstruction. I started off using autograft for my MPFL reconstructions back in 2011. I found sometimes I had issue with poor graft quality and poor graft length, which meant that I wasn't very happy with the femoral tunnel fixation. I then moved towards a Lars ligament as I wanted something more robust, but the Lars tubular ligament was palpable beneath the skin of the medial patella and the medial knee. I then moved to a flat tape, which is a polytape type of construct by near ligament, and that worked reasonably well, substituting for an MPFL, but the handling properties were quite tricky in terms of trying to whip stitch it. There was a lot of fraying, for example, of the whip stitched ends. Then I moved to the Infinity Lock 5, and I've been using that for the last 10 years or so. It's an excellent graft to mimic the MPFL in terms of its length. It's an inert polyester flat tape which is not palpable underneath the skin, and it's very easy to whip stitch and handle. So very happy with that for the last 10 years. So benefits from a patient's perspective using synthetic is one less scar. Certainly you don't need to take the hamstring tendon, which tends to be semitendinosus. It's quite an important tendon in terms of hamstring strength, so your rehab is and your pain post-operatively is less with a synthetic. You don't have complications of graft harvest issues such as hematoma or numbness around the graft harvest site. The rehab is a lot less strict than when using an autograft. So I don't use a brace at all. I let them fully weight bear straight away. I've had no problems. I've had 0 redislocations of my synthetic MPFLs, and I've very, very little in the way of stiffness. Tips and tricks with a synthetic graft is similar to any graft that you use for MPFL, is to put it in a detension state. It's, like I said previously, it's really easy to handle. You're not ever worried about graft length because it's more than enough graft length. You treat it exactly like you would as an autograft, and put it in the correct femoral tunnel position using fluoroscopy, and I attach it to the patella using all suture anchors, and it's absolutely fine. There's no issues with it. So the future for synthetics I see as pretty much overtaking or superseding allograft. Allograft, as we know, is difficult to get. It's extremely expensive. Sometimes the allograft you order isn't the allograft you order. More and more we're looking for something that's going to never stretch. It's going to be structurally sound. It's going to synovialize with the host tissue, which is exactly what the modern synthetics do. And so I don't really see a need for allograft, which is still a very popular choice, and I don't see why. Reluctance to use synthetics is probably a legacy from poor quality synthetics that we used in the past in knee surgery. And when people think of synthetics in the knee, they think of immediately think of Gore-Tex or Dacron grafts that we used in ACL, which catastrophically failed. These modern synthetics have got a long heritage, going back to the Leeds Keo polyester ligaments. There's a host of very good papers out there to say that it's safe and effective, and certainly in my experience over the last 10 years, I've had no real issues with my graft in terms of soft tissue reaction, stiffness, osteolysis, anything like that. I've had 0 redislocation because it will never stretch, and so I would say it's particularly useful if you are thinking about changing to start using it in those collagen deficient patients, for revision cases, and even paediatrics when you're reticent to take a hamstring tendon at a young age. And the other advantage of synthetic MPFL would be as a part of a multi-ligament surgery scenario, or when you want to use hamstring for another reconstruction.